Thank you everyone for joining us tonight. We'll be talking about treatment rejection and wellness coaching, but before we get started, just a couple quick things to mention. You're all muted. If you do have questions, make sure on the right-hand side of your screen to type them into the questions box. At the end of the presentation, we'll have some time as well to answer some of those, and if we run out of time, we will make sure that we get back to you guys via email. So make sure to keep them coming in. Anyone that wants to learn more, also contact us to schedule a meeting with your team. We can schedule those one-on-one with you. So with that, I'd like to introduce Dr. Kim Coop, CEO and founder of Carifree. For anyone that hasn't heard Dr. Coop speak, he's been pushing the boundaries of dentistry for over 35 years and is the leading authority on ATP as it relates to caries risk assessment. I know that we have a lot to get to, a pretty packed hour, so I'll turn it over to you, Dr. Cooch.
Hey, thank you, Cody, and welcome everybody. We've got a lot of people on the line tonight. That's really exciting. This is one of my favorite topics, and I have to give you a disclaimer before we start tonight. I can't teach you wellness coaching in an hour, but certainly I want to give you some things to think about tonight and maybe give you some new questions to ask and look at your patients a little bit differently. So with that, let's get started here. You know, I want to kind of set the case up for you to help you understand kind of what got me into coaching to begin with. And literally it came out of my dental caries, I guess, focus in my dental practice, because I noticed some real change in my patients and their attitudes as a result of what we were doing there, and that led me into the coaching world, where I went through a 2-year coaching program and got certified with the International Federation of Coaching. And so it's a real life skill, and it's something that I kind of want to just share with you because it will help you with your patients. When we look at, talk about the global burden of disease, whether it's periodontal disease or dental caries, this is our most recent data. It's increased by 45% from 1990 to 2010. So we've got an epidemic of disease that continues to grow even in all countries, including the United States. And I know that you guys deal with these issues, whether it's children, the decay rate in children continues to go up, or whether you're dealing with senior patients who may have Alzheimer's, or maybe in partial care facilities or what have you. We're dealing with a lot of disease here that we're trying to help people with. And I got involved early on with caries management in Canberra with John Featherstone, Doug Young, and that whole group of individuals. And one of the things that we did was we made it pretty complicated. I think we always have a tendency, particularly scientists, have a tendency to make things more complicated than maybe clinicians can appreciate that they need to be to function well in practice. And so one of the things I've been teaching for the last few years is the concept of really just pattern recognition. And so, looking at the mouth in terms of their disease, what kind of patterns do you see? And particularly when it comes to dental caries, I talk about the usual suspects. There are patterns for this disease and major risk factors, groups of risk factors that you're going to see that really can guide you rather quickly to where this patient's at, what's causing their disease, and then start to think about, well, how am I going to coach this patient through that process? So I talked about the usual suspects and, what's causing this pandemic of dental caries globally. When we look at our own data from our own multi-site research study that we've had going on now for about 4 years, 63% of the patients have a problem with saliva. They're self-reported xerostomia or hyposalivation. 55% of the patients are either, admit on the form that they are either eating too much sugar or they're snacking too frequently. Bacteria being an issue in the mouth, an overload of bacteria, either as a function of poor home care or maybe the wrong bacteria in their mouth. Our data runs somewhere between 46 and 51%. Certainly in the last 6 years now, genetics is really, that whole field in terms of dental caries is developing, and actually that new data now should, instead of 40 to 55%, should say 30 to 60% of all dental caries can be explained by genetics alone. So certainly that's something that we have to kind of learn how to factor into our equation and start to look for. And then at the end of the day, it's all about pH. It's those prolonged periods of low pH in the mouth that lead to mineral loss, and cavitation of the teeth. And so it's really about being able to recognize quickly a pattern and then being able to work with the patient through what's causing that pattern. Certainly now we've got over 54 bacteria that have been identified as potential carcinogenic bacteria. This is not a mutant streptococci lactobacillus disease anymore. And recently we just added, in the last year, added Candida dublinesis. We've always known Candida albicans has played a role in this disease. It's highly acidic, but now we've added another species there as well. We know that Americans eat way too much sugar. I'm not sure how to solve this issue. You limit the sodas to 20 ounces and they buy 2 of them instead of 1, and now they're drinking 40 ounces instead of 32. I mean, I don't know how to solve this. This has to start, it's a generational thing. This has to start with education awareness, I think, in our children when they're in grade school. But that's a real challenge for us in terms of just the amount of sugar and what it does to our health needs in this country. Saliva, the prescription medications in this country are we're in a pharmaceutically industrialized, run, capitalistic, country, and the reality is, I mean, you see it, I see it. Our patients are taking, 8, 10, 12, 15 medications, and the number one side effect is hyposalivation out of those, and you start to just take the saliva away, and suddenly the entire mouth is out of balance, and that's a real recipe for a disaster in terms of dental caries. And then genetics, we know there are certain actually geographic manifestations of dental caries in the mouth that we know can be identified or traced back to specific genes. So, we're learning more and more about this as time goes by. But this is really, I included this study because this is really at the heart of the matter. And whether you're talking about dental caries or periodontal disease, whatever, we need to look at the patient at a person level. This is a person-level disease. It's not a tooth level. It's not a tooth surface level. I mean, here we've got, dental caries has increased 45% in the last 20 years, and globally, and, our profession had spent 10 years developing a new caries classification system that was even yet more complicated, as if that was going to solve the problem. Dealing with this at a tooth surface developmental level, when really, if we're going to conquer this disease, we need to start looking at it at a person level. We need to start looking at this as a disease the person has and try and figure out what those risk factors are so that we can precisely target our strategies with that patient to help manage and effectively control that. And so that's really, where the coaching part comes into this. It's about us being able to help look at that person and look at the disease differently. And I've used these slides in the past, and I think it really, it just brings home kind of the point I'm trying to make here. If we look at through our scientific progress over the continuum of mankind, we start out with intuitive medicine where, I kind of think if I do this for you, you're going to get better. And then we advance to empirical where I know, people I give this to, I kind of see this kind of response. And then we get to the point where we have evidence base of, randomized clinical controlled trials, and we have our best level of scientific evidence that I know that if you have this condition and I do this for you, I should get this outcome. Or a certain percentage will get this outcome. And we know how to predict that. And so really, and that's what we're trying to get with precision or targeted medicine in dentistry. So I'll show you 2 patients here. They're both high risk. They're both high risk for dental caries. They're both averaging 2 new lesions per year. Now, I think you can agree with me that the patient on the left, what's the risk factors, the usual suspect driving her disease is different from the one on the right. And so, we need to approach these at a person level rather than at a tooth surface level. Because, in intuitive medicine, what we would do here is we would drill and fill. We'd see a hole in the tooth, and, this is how I was trained. Many of you were trained in dental school. It's like it was tooth level, tooth surface level. You saw a patient, and the diagnosis was a restoration. It's just so inappropriate in terms of how we're going to manage this disease. But that's how I was trained. It was drill and fill. And then we got into empirical medicine. It's like, well, we started to look at a medical model, and we would treat these patients both with chlorhexidine and fluoride. It was kind of a one-size-fits-all thing. And I think you can also appreciate that, the chlorhexidine, well, I don't use it anymore as an antimicrobial agent, haven't for years, but to use an antimicrobial agent on the patient on the left is probably going to help that patient. the person on the right doesn't need an antimicrobial agent. That's not going to help them at all. That's not their problem. So to create these one-size-fits-all therapies or strategies for our patients as we're talking about their treatment planning doesn't make sense. So if we go forward, we really need to, in terms of precision medicine, we really need to target our therapies and our strategies for the individual risk factors that those patients exhibit, so that we can be more effective at helping them overcome and effectively manage that disease process. So the suspects drive the treatment strategies. So if you've got a patient that has a bacterial issue, we need to look at one of two things. We either need to look at using an antimicrobial agent to help them reduce their bacterial load and maybe change the bacteria that are in their mouth, or we need to help them with their behavior in terms of home care. That's where coaching comes in to, working on things like home care. Diet, if they've got a diet problem, they're either eating too much sugar or they're eating too frequently. And so we need to help coach them on, do they need to limit sweets overall, or do they need to figure out a new strategy to eat? I had a patient, new patient came to me, referred by another dentist locally. The guy's a veterinarian. He's 45 years old. He became a marathon runner 5 years ago. Hadn't had any cavities in his whole, since he was a child. And suddenly he's developing 3 and 4 cavities a year and couldn't figure out why. And this has been going on for 5 years. They're refilling these spots. And, I sat down and started visiting with him about that. And the topic of, well, tell me your eating habits. What's changed 5 years ago? Well, I started marathon running, and so now I carbohydrate load. Well, tell me about that. Well, I'm eating, I don't know, Nugu or something, which is basically puttied sugar, and he's eating it like all day long. Well, it's like, okay, I think I know what the problem here is, and you can still carbohydrate load, but you need to understand that that's what's causing that whole caries process. And I explained it to him, and he had all the information he needed to go make that change in his life. I didn't need to see him again. And that's part of the coaching process, and we'll get into that. Saliva, you've got the patients that have dry mouth. And, I mean, you see this every day. I see it every day. And this is probably one of the biggest challenges we have. And then if you recognize a genetic pattern in the patient when you look at some of these, all you can do is, I can't change your DNA, but I can help you understand how you can be healthy and support that wellness as much as I can. When we get into treatment plan rejection, and this is the thing that this is kind of the nail on the head here tonight. It's like, how many times have you heard the patient say, I'm never going to have another root canal. I'm never going to have another crown. I'm never going to have another bridge. I'm not doing that again. That was a waste of time. That was a waste of money. And the question is, why are they saying that? And they're saying that because restorative dentistry by itself doesn't solve this disease. And so one of the big rejections that we have and that we face is because, and it may be the unspoken, the patient won't tell you that, and some patients will tell you what I just said, and I know that you've heard it, but one of those challenges that we've got is that they've had failures, with restorative dentistry. Because why? Because it was empirical medicine and intuitive. It wasn't precision, and we didn't figure out what was causing and driving their disease. We didn't help them figure out how to manage that effectively. And so at some point in time, they throw in the towel. And, I always wonder, like, where I'm going to find material for some of these topics. When my team and I, think we really need it. This is a topic that I think there'd be a lot of interest in. And I really don't have to go too far in our profession to find a lot of support. But this is from, the CEREC Doctor, Journal. And this came out this last year. And I was struck by this because this is really what we're talking about here tonight. And don't get me wrong, I have a CEREC. I use it every day. I love my CEREC. And I have very close relationships with a lot of people at Sirona. And so this is not about CEREC. This is about how we're trying to use it. And, it's like digital dentistry is now somehow going to replace the laboratory restorative dentistry, and it's somehow better. This is the before of this patient. Now look at this patient. I want you to look closely here. Look at all the decay that you see in this mouth. And I got to tell you, this patient had a mouthful of restorative dentistry, and I'm not going to assume it was all bad dentistry. I'm going to assume it was good dentistry, and that the margins fit, and that that it looked nice, and everything was appropriate. But look what happened to it. And take a look at these radiographs and look at look at number 6. I mean, that needs a root canal. Probably number 11 does. Some of these teeth may need to be extracted. They've already treatment planned for more implants, and they've already had some implants. This patient is going downhill with restorative dentistry, and now we're going to do it with a CEREC, and as if that's going to solve the problem, right? I mean, this person, I wouldn't even be doing these restorations on this patient. This is a patient I would take. This is a call for a timeout, and it's like, until we figure out what's causing this and help you manage it and get it under control, there's no point in investing another dollar in any restorative dentistry, because it's going to fail. And the fact that this patient it already had all of that and they're ready to do it again is a surprise, because at some point in time, the patients go, I'm never having another, I'm done having those, they failed, I've spent $30,000 the first time around, I'm spending $30,000 again. How many times is a patient going to spend $30,000 or $40,000 on a full restorative case every 3 or 4 or 5 years before they finally go, I think we want to talk about doing something different here, and as if this is going to change. Restorative dentistry already failed this patient. When you have the patient that's pushing back and resisting restorative care, think about the fact, ask yourself, is this patient saying that because they've already had experienced failures from the restorative care, and why have they experienced those failures? And it's probably because we didn't actually get to what was causing the disease. We were looking at tooth level and not person level, and we weren't dealing with risk factors. Because one of the biggest shocks that came to me early on, and when I started doing Carrie's risk assessment, and this has been 15 years ago now, almost 16 years ago I've been doing this, and after 2 or 3 years I had these patients that were now decay-free, and the system was working, and I helped them manage their disease effectively, and suddenly they were asking me about 5-unit bridges and things that I'd presented and been rejected so many times. I'll even ask it 10 or 12 times, but after you say no to that 5-unit bridge like 12 or 13 years in a row, I finally quit asking, because you've convinced me you don't want it. And then 2 or 3 years later, for you to come back and say, hey, can I have that now? Okay, there's a question in my mind. The first question is like, why? Why do you want? And I asked them, why do you want that now? And the response was, because now I know that it'll last. And it was like the light bulb went on for me. The reason they didn't want it was because all of the other money they'd invested in restorative dentistry hadn't lasted, and it seemed like a waste of time to them. And so once they got healthy and they had confidence in their ability to stay healthy, the dentistry was going to last. And not only did they want, they wanted to remodel the entire house. And that was shocking to me, and surprise. It shouldn't have been, but it was a surprise. And so really then I didn't have the skills on how to coach them through some of those issues, particularly with behavioral management. If it's an issue, you need to change your diet or improve your home care. Yeah, we were taught how to show somebody how to brush and floss. I was taught how to tell them how they ought to floss and how many times they ought to floss every day. Telling somebody that over and over and over again doesn't change their behavior. And so that's when I went in through the coaching program, because I wanted to gain the skills for myself on, well, how do I do that? Because I wasn't trained on that. As dentists, we're not trained on that. And so, here's just a paper from the Journal of Dental Research back in 2012 that talks about these high-risk patients. It's not drill and fill. We need to, if we're not effectively determining what's causing their disease and doing all of these other strategies for them as appropriate, it's not going to be successful. And some of that is plaque control education, but I really want to talk about coaching in that situation, or diet advice and helping them through that, along with all the things you would do for the high-risk caries patient. I'm talking about fluoride varnishes quarterly, and a 5,000 part per million fluoride gel, and just helping them understand what's causing the disease. But it really gets to be more than that. When we start talking about behavioral change, which is if you're going to resolve some of these treatment rejections, we really need to look at our ability to help them make behavioral change. So wellness coaching is really a process. It's a profession, but it's a process where coaching helps the patient understand why they have the problem they have, and it empowers them to do something about it. So some of you have probably been through the motivational interview, and this isn't really about motivating somebody as much as just helping them understand and then helping them, coaching them through a process of discovery and then them resolving. All the work is done by the patient. When in terms of coaching, it's like the coach doesn't do any work. The coach asks the questions and lets the patient do all of the work and sort it out and figure it out for themselves. So that's really, the basis of coaching. And the first thing that I did was read this Wellness Coaching by Michael Orlowski. You can order this on Amazon. I would tell you it's a very slow read, and it's a good book. But again, it primarily targets physicians and nurses, but it's in the healthcare environment, and it goes through different scenarios, and it shows how we typically ask patients questions, and then it goes back and says, well, what would have happened if we had asked this question? How about if we had, instead of asking this yes or no question, if we'd asked more of an open-ended question or asked, the patient, approach them differently. And then, of course, Ferocia Knight, a lot of you, if you know me, you've heard me talk about Ferocia. She was my coach, still is my coach. She's an amazing individual. And so I went through her coaching program for 2 years. And it was, just invaluable, the skill that I developed. I have to laugh now because I went through the program. Basically, my only interest was learning how to coach patients to make the behavioral change to control dental caries. And what you come out with is a life skill that helps you really communicate better in all of your relationships, whether it's with your patients or your friends or your family. It's really, it's a lot more global than tooth level. It's more person level and even relationship level. So one of the things that we hear is if I ask you how long does it take for a person to develop a new habit, and I think the urban legend is that it takes 21 days, or sometimes I hear 28 days. So I went back and looked at, well, where does that come from? I want to look at the science behind this 21-day thing, because I got to tell you, that ain't my experience with my patients. And so in doing research and tracing this back, this is quite interesting. This is a textbook by Maxwell Maltz. He was a prominent plastic surgeon back in the 1950s, and he wrote a book in 1960 called Psycho-Cybernetics, and he made this observation that it seemed to take his patients about 21 days to get used to their new face. And so this whole myth about the 21-day, taking 21 days to create a new habit, it's literally a myth, and it comes from one observation from one plastic surgeon who guesstimated that it took about 21 days for his patients to get used to their new face after the surgery. That's about as unscientific as, it's observation, but I got to tell you, the 21-day thing is hokum, to quote Dr. Sheldon Cooper. And if you start looking at this psychology journals and human behavior, studies that have been done, and this was a study that was done on a few hundred adults, and they followed them over a span of about 3 years, and they looked at the different types of behavioral changes or habits that these people were trying to establish. And what they found is that, it varied by how difficult the new behavior was, and it varied quite a bit between individuals as well. So there isn't like some magic 21 days and every human being is going to have a new habit. It actually, within the study, these new habits, if they were going to be sustainable, took anywhere from 66 to 254 days to develop that new habit. And I would tell you, I would put a lot more weight on this. In fact, some of the data that we see coming out of the Cleveland Clinic appears that it takes something like 8 months to establish a new habit, and that's with daily reminder and prompting for the first 6 months of that, so to make it sustainable. So I think if we really want to talk about, how do we help a patient develop a new habit, this is more of a long-term proposition. This doesn't happen in 21 days. So the other thing that we also know about that is that our attitude has a huge impact on the patient's ability to make changes. And so, one of the things, if you're sitting there with a negative attitude, like, and it's hard for us not to, to develop attitudes at times, with our patients, because it seems like, they continue to come in, they continue to fail, they continue not to make the change, and, at some point in time, you just kind of like, why do I bother if you really don't care yourself? I mean, but on the other hand, if we can help support them and encourage them, and that helps motivate them as well. It's like being told, I don't know if you've ever had this experience in your life, but being told by somebody else that you maybe considered authority that said to you, I believe that you're going to be really, really good at that, or I can see you doing that. I picture you being able to accomplish this. I see it in you. And maybe that has a huge impact. I know it has on me at different things that I've attempted to do in my life where I thought, I'm not going to be that good at this. And somebody said, no, I think you're going to be really good at that. And it encouraged me to take that, to have the confidence to take that first step and actually go make that change in my life and discover that, you know what, they were right. And I wonder how much of that was the fact that they really did see it, or maybe they were just encouraging me, and that's all it took to help motivate me. But I know that our attitude has a huge impact on how our patients respond and if they're going to be able to make changes. And the other thing that we need to be really careful about being with the patients, and coaching is all about this, is be non-judgmental. This isn't a lazy person who doesn't brush their teeth because they're a crappy individual. This is a person who hasn't been able successfully yet to make that change in their life, and they have a disease or they have a situation, and they really need our help. And so being non-judgmental about that, because again, I think it's easy for us to develop an attitude or be very judgmental with our patients, and we always have to be cognizant of the fact that being non-judgmental, this is a person who has a problem, and I'm here to help that person. And so it's a whole person that has a problem. It's not a problem person. And so I think that that's the attitude certainly that we need to look at. And then we need to be realistic as well, particularly if you're talking about behavioral change when it comes to diet, particularly sugar. There's good scientific evidence that it's more challenging and difficult for a patient to make a behavioral change around their sugar habit than it is around alcohol. And we all know that alcohol is not an easy, it's very addictive and not an easy thing to make behavioral changes around, and that takes 12 steps, right? Sugar addiction may take 12 or more steps, but I think that's something that we need to be kind of aware of. This is not an easy thing for patients, and particularly, God, we're surrounded by sugar. It's in everything you buy to eat. There's added sugar in anything that's packaged, and why? Because it's addictive, and then you're going to eat more of it, and it's a real challenge, I think, for us in our profession and in our society. And then we've got one more challenge for helping a patient develop a new habit, and that's called proactive interference. And proactive interference is they already have an established habit. And a lot of times the established habit interferes with us being able to develop the new habit. How many times have you shown a patient how to do circular brushing, the Bass technique? How many times, and yet they still brush back and forth in a linear motion? And you can show them over and over. The problem is they've already got this established habit of brushing back and forth, and that interferes. If they'd never brushed their teeth and you showed them how to do it correctly the first time, it would be a lot easier than if you have somebody who's been brushing their teeth that way for 60 years and now you suddenly expect them to change. So the reason that we have some of the challenges that we have is like their existing habits. We have to help them unlearn the old habit to be able to learn the new habit as well. So this is just some of the scientific information that I wanted to share with you. And it really gets down to when you talk about treatment rejection, the whole point here that I want to make tonight, and I want to give you some new questions to ask, and we'll go through this now, but it's really, are we telling them what they need, what they should do, or are we asking them what would they like to do? What do they think the problem is? How would they like to solve it? Where do they think we should start? Am I your advocate on helping you get what you want, or am I a salesperson trying to sell you something I think you should have? And that's a huge disconnect, and I know that selling often gets a really dirty word in dentistry, but I really think we need to quit thinking in terms of selling and thinking more about we've been telling people what they should do, and we really need to start asking them what they want. You know, the most successful car salespeople, you don't go to a car dealer just to look at new models for fun. You know, there's nothing fun about going through that process. The only time you walk into a car dealership is when you're thinking about buying a new car. You don't get up in the morning and go, I don't have anything else to do. I think I'll go, you know, wander down the car dealership and be abused by a salesperson. You know, we don't do that. So when you go in there, you have an agenda and you have something that you want. And the most effective salespeople, quote unquote, are the ones that don't focus on trying to sell you what they have on the showroom floor, but rather ask you what questions, what are you looking for, what are you trying to solve, what needs do you have in an automobile, and suddenly you've got somebody there that can then help you get what it is that you're looking for. And that's really how sales has changed today. Rather than trying to, you know, sell you something you don't need or want so I can get a commission, it's more about, I really want to know what it is. I want to understand, listen and understand what it is that you need, that you think you need, that you want, and trying to help you accomplish that. So that's really where we go with coaching. And we're really good at asking, as dentists and hygienists, we're really good at asking closed-ended questions. Do you floss? You know, there's no point asking a question of a patient, do they floss? Because the correct answer is yes. And you know they're lying. If you look in their mouth and they tell you they floss, and you know they're not, or they haven't, or, you know, you get the honest patients who often, you know, once in a while have a patient will say, Doc, you don't remember, you know, when I last flossed because you were there, right? It was 6 months ago. You know, so they know the right answer, and then if you ask them, well, how many times do you floss a day? Well, they're going to say 2, you know, because they think that's the right answer, and we're not getting anywhere, and it's judgmental, and it's puts them on a defensive. You know, these are coaching questions, so I want you to write some of these questions down. The most important question is to ask the patient is, what would you like to focus on? You know, we used to ask them what their chief complaint is. You know, what a horrible question. But, you know, better to phrase it, how can I help you today? You know, why are you here? You know, is there something that, you know, tell me in your words, you know, why you're here and how I can help you. I always ask new patients, how can I help you today? You know, what can I do for you? And, you know, then I find out what their agenda is. And they didn't show up at the dentist's office randomly, like they didn't go to a car dealer. They have an agenda, and as long as I'm telling them what I think they need and they should do, I don't really ever get to find out what their agenda is. And I had 2 new patients, one yesterday and one today, that came from other dental practices, and I'm going to talk about that a little bit, because these are the mistakes that we typically make in the profession. You know, these are some really good open-ended questions. Tell me how this has affected your life. This anchors them to an emotion. And if you're going to ask this question, I would encourage you to have Kleenex in the room, because it may be very emotional for this person. They may be ashamed of their teeth. You know, there are all kinds of baggage that is associated with dental caries and your smile. So I would say be prepared for a patient to start crying, male or female. But it's a great question to ask people, tell me how this affected your life, because I want to know, is this a really important issue to you or is it not? And you need to hear from yourself whether this is important or not. And another really great comment is to, in a non-judgmental way, to say, that's interesting, tell me more about that. And I have to tell you, anytime, human beings love to talk about themselves, and if they have somebody that's enjoying listening to them, and you ask more and more questions, that's interesting, tell me more about that. I can learn a lot about that person by asking that, because they'll tell me. So rather than me interrogating them, I'm inviting them to tell me more, share more, say more about that. Is there more that you could share? You know, those are the kind of questions that you want to ask to help that patient bring those, you know, topics out to you. So let's go back real quick. I just want to kind of make this practical for you tonight. So this is the patient that we looked at earlier tonight. She was 38 years old when I first saw her. She was from Alabama. She had infrequent dental visits. She had, you know, if we look at her medical history, there's nothing there that is contributing to this disease. Her blood pressure and pulse rate were within normal limits. She was, you know, a little anxious. If we look at her radiographs, I think that we're all on the same page. This person is high risk for dental caries. Now, I could sit down with this patient and start saying, okay, You need to have tooth number 2 extracted. You need to have tooth number 15 extracted. You need to have buildups and crowns placed on teeth number 8 and 9. You need to have a crown on a DO filling on tooth number 5. You need to have a crown on, I don't know, tooth number 20 or 21. We could go through that typical scenario. This is how, and here's the treatment plan. And the first appointment, and we're going to do extraction of 2 and 15. Here's what the cost is. Here's how much your insurance pays. The second appointment, we're going to do this. The third appointment, we're going to do that. And the fourth appointment, we're going to do this, and etc. And that's how we were trained. And I have to tell you, I had a patient yesterday, a senior patient that came to me yesterday for a second opinion, and she had 2 mobile teeth. She had 8 remaining teeth on the lower with a existing partial. The partial fit okay. The teeth had the 2 anchors had 21 and 28, had class 3 mobility. They'd lost about 50% of their bone. The rest of her teeth were completely sound. There were no other issues periodontally, etc. And she had been given a treatment plan by a periodontist that involved and there were 8 appointments, and it was very well organized, but 8 appointments of, here's the first appointment, we're going to do this, we're going to do the deep cleaning first, we're going to do all of that. It was all appropriate, and it's what we were taught to do. And then we're going to do the soft tissue grafting before we extract the teeth, and then we're going to do the bone grafting, and then we're going to do the implants. And then, you'll go back to your restorative dentist, and they'll restore the implants with crowns and abutments, and then you'll have a new partial made. The total cost of this whole treatment for this gal is like, close to $20,000. Now, cost is not an option. And I said, so how can I help you today? And she goes, I just want to know what my options are. Like, nobody ever asked me, well, what I would like to do or what other options are there besides the implants. She said, if the implants, if you tell me they're the best way to go, I can afford it. I just want to know, well, what if I do that? What if I don't do that? Is there something else I could do? And nobody ever stopped and said, well, what would you like to do? Which is what I did. I said, well, what would you like? And, patients, I learned this from Bill Blatchford a long time ago, and it's very simple. Patients want to look good, they want to feel good, and they want it to last a long time. And literally, that's what she said to me. I want my smile to look nice. I want to be able to eat. I'm worried about these teeth breaking and coming loose. And I just want it, whatever we do, to last a long time. And I said, okay, so let's talk about all these different options. So I went through about 4 or 5 different options with her, and then I said, and now because you were a second opinion, I want to refer you back to the dentist that you first saw and the periodontist, and now you know that there are options, whatever. And she said, no, I don't want to go there. She said, I didn't have a good experience, and you're the first person that listened to me. She said, you really listened to me. And I think, it's just so important. We get so wrapped up in wanting to tell them what we see and what's wrong, and we want to tell them what we know. But the most important thing we can do to the patient is listen to them, because they'll tell us what they want. They'll tell us, what they're interested in, and then it's just a matter of making sure that we heard them and that we understood that. And so we'll talk about this. So this patient, we look at, what do you think the usual suspect? Let's go back a couple of photos. Usual suspects. Obviously, this person has a bacterial issue. She's probably got the wrong bacteria growing on her teeth, and she certainly has too much bacterial load, and that's a behavioral issue. So I know, just looking at her mouth, that one of the biggest challenges we've got here is we need to establish new home care regimen for her. Her diet may be playing a role. She seems to have plenty of saliva, so we're looking at her diet. Well, it turns out she drinks something other than milk or water more than 2 times a day, and she's highly motivated. Right? She wants to do whatever it can, whatever she needs to be able. She wants to save her teeth. That's where we're at. So, this is a high carries risk, extreme carries risk, active, high. Label them however you want. This person is that you start putting fillings and crowns on those teeth, and I guarantee you, in 6 months or a year, they'll be back with recurrent decay around those crowns. So it's like there's no point in doing that until she understands what's causing this problem in the first place. So you may want to go through a provisional restorative phase where you plug holes in the teeth. As a clinician, I do that for patients like this. I don't think that it makes sense to just start diving in, putting definitive restorations in that. And I had a educator questioned that as it was motivated by finances. It had an entrepreneurial motivation that I would want to put provisional or restorative things for this patient while I worked on trying to get her into a healthy balance. I got to tell you, that's somebody who's never practiced clinical dentistry. And to, my motivation is to get this patient healthy so that when I do put those final restorations in, I'm not going to be replacing them 12 months or 24 months or 36 months from now, or I'm not creating another patient who's going to walk into the next dentist and say, I'm never having another crown or I'm never having another root canal because that was a waste of money. And that's the mindset that you and I have to change in this profession, and it has to start with you and me, and we have to teach our educators. So anyway, I'll get off my soapbox, but that pisses me off. So, we learned from this patient that she drinks Mountain Dew, like a lot of Mountain Dew every day. Okay, I think that's a dietary issue, and she understands that she's not good at brushing her teeth. So, I would tell her, you need to stop drinking Mountain Dew, and you need to start brushing your teeth, and let's show you how to brush your teeth. And that would be our approach, but that doesn't work. So, if we were going through a coaching model with this patient, now we talk about, I do have to repair those teeth. I'm not going to let those lesions continue to grow. You might use silver diamine fluoride on this patient. And, as long as they know those lesions are going to turn jet black, but that might arrest the decay. I had that conversation with a patient last night. Let's do this first, and then let's see if we can get your xerostomia under control before you do anything else. Let's just see if we can arrest these or try and plug the holes. Get our fingers in the dike, and then we can go from there. We got to think about therapeutic recommendations, like probably an antimicrobial agent here for this patient for a long time, like maybe a year or 2 years. And then we need to start talking about behavioral changes with her. And then we need to set a recare schedule that's appropriate. For this patient, this is every 3 months, in my opinion. So we've got these usual suspects. So let's talk about how would you coach this patient? Well, the question, what would you like to focus on? This is what I hear from the patient. I want to save my teeth and I want to stop getting cavities. She doesn't want her, and additionally, she didn't want her 2 daughters to be afraid of the dentist, and she doesn't want them to have the teeth and experience she's had. The outlook. So this is an acronym FOOT, and actually this is, I have to credit Ferocia with this. Typically coaching sessions are an hour long. I don't have an hour to talk to the patient about this, nor does anybody on my team, because we're not getting paid big coaching dollars to do this. So I have to do this. She designed this to be a 7-minute. This is really a 4-minute coaching model. And I do have 4 minutes to talk to my patients and help coach them, and so does my team. The outlook, and you can think of that as what are the challenges, or you could use the word obstacle, but I really hate that word. I like the outlook. She's a dental phobic. We know that, and she recognizes that she's got bad habits that she's going to need to change. Opportunities. What do we have going for us? What's in our, what's in our corner of this ring? What do we got that's here that's an advantage that we've got going for us? Well, she's highly motivated and she has really good dental insurance, so this is not going to cost her a lot of out-of-pocket. She can afford to do whatever she's going to need, or decide to have done. And then we talk about targeted strategies. Antimicrobial therapy, I think that's appropriate for her. We need to stage the treatment. I'm going to go through provisional care for her. I think it's crazy to put definitive restorations for this patient out of the gate. They end up like the digital case of the CEREC I showed you. That's just stupid. I can't think of a better word than stupid. And then we're going to work on wellness, and we're going to talk about the behavioral change. She has 2 things to work on. Her diet, she needs to change the Mountain Dew habit, and she needs to work on brushing, and then flossing. Now, if there's one thing we know in the coaching world, humans are only successful at changing one thing at a time. And so God, I see these treatment plans or these plans that people put together where they have to do these 18 different things during the day and they're all new. They're not going to do that. I mean, I'm going to dance up and down if I can get this lady to stop drinking Mountain Dew or even switch to Diet Mountain Dew to start with. I mean, that goes in the victory column. If I can get her to brush her teeth once a day, she and I are going to celebrate that. So it's like, I'm not trying to do everything all at once. We have to break this down and make it small baby steps so that they can be successful at it. And once they've made the first change, they can make the second one. And how do you decide what you do? What do you do first? What do you think we should do? Like, where would you like to start? You've got two things here that you need to change, right? You recognize you've got a behavioral issue with the brushing and then flossing, and you also have the dietary issue that's causing this problem for you. Which one of these, I want you to pick one, which one do you want to work on first? And she picked the Mountain Dew. And I said, how are you going to do that? Like, tell me, explain to me your plan. So you put the, I'm not going to tell you to just quit drinking Mountain Dew. I want you to figure it out, and I want you to tell me how are you going to do that. And I'm going to help you. I'm going to coach you so that you solve your own problem by continuing to ask questions. Where would you like to start? How are you going to start by doing that? And she laid out for me her plan on how she was going to quit drinking Mountain Dew, and literally within a matter of a month, she had accomplished that. And she said, now I'm ready to work on the brushing. Can you help me with that? Yes, I can. And so I gave her some ideas on how she might remind herself, because it has to be tied to a trigger. For me, I started flossing because, you guys, I've shared this many times, every time I turn on the water in the shower in the morning, that's my trigger to go grab the floss and floss my teeth. While I'm waiting for the water to warm up, that's all the time it takes for me to floss my teeth. And so that's the trigger. Every time I turn on a shower now, and it's been my habit for years, but you just need to tie it to a trigger so that it reminds you. How are you going to remind yourself to do that? Maybe it's paste a note on your mirror every time that you get up in the morning, or every time you do this or do that. I want that to trigger that thought for that new behavior for you. And so, I mean, this is a 4-year process. This is where we're at with this patient. And I got to tell you, I've watched the process. It's not linear. She's got a long ways to go, but when you look at where she started, she has come a long ways, and we celebrate the victories along the way. And I'm really proud of this person. She's made some really significant changes in her life. Yeah, is her home care perfect? No. But you know what? Compared to where we started and what we started to deal with, she's made huge progress, and I'm really proud of her. So the questions become not, here's my treatment plan, here's the 8 appointments, here's what you're going to do, we're going to do on each one, here's what you need to have done, and here's how much it's going to cost. And I used to sit down with patients and phase out, here's phase 1, phase 2, and phase 3. I don't do that. I quit doing that after I came out of the coaching program, and it's like, where would you like to start? And I had this new patient today, and she has a couple of large cavities. Her teeth are sensitive. She wants to get those fixed because they're bothering her. And then she's got all of these old crown and bridge and crowns that she hates. And one of them is tooth number 9, and her natural shade on her teeth is about a C2, between C2 and C3, and the crown on number 9 is B1. And she hates it. And as I'm listening to her, and she's explaining these things to me, and I said, well, where would you like to start? I'd like to start with this front tooth. After I fix the 2 teeth that have the big cavities, I want to go here. Is that okay? And I'm like, absolutely. We can arrange this in any order, but I'm going to do that. I'm listening to you. And she was so excited to know that, that was going to be the next thing, because she really hates that. And when she was done, she said to me, you really listened to me. And I just think, just the second time I've heard that in 2 days, and it's not, that's a skill. We just need to stop ourselves and listen more, talk less and listen more. So it's a matter of, what would you like to do? Where would you start? What would you like done? And, it's just, you're gonna see an amazing response from these patients when you start asking those kind of questions, and you're going to have a lot less reluctance, because it's not your treatment plan, it's their treatment plan that they created. And I know we used to do this co-consult, back in the 90s, where we sit down side by side with the patient and go through their treatment plan and kind of, but it's really more a function of, where would you like to start? How would you solve this? What's going to work best for you? And then just a matter of, stopping and asking them and listening to, what it is that they want out of that situation. And that's what coaching is all about. So in conclusion tonight, I just want to share this with you. And I want to make sure when you're listening, I don't know if anybody's ever been through an active listening seminar. Oh my goodness. It's so obnoxious. Yeah, it's effective, but it's obnoxious. And if you've ever had the person say, so what I hear you saying is, and then they repeat exactly back what you said. And then you say something more and they go, no, so what I hear you saying now is, and what I hear you saying is, about the third time somebody says to me, what I hear you saying is, I want to reach across the table and slap them, right? So it's more like use your own words. So it sounds to me like you want to start with that front tooth. And that's, I mean, she wanted to hug me when I said that. She goes, yes, that's exactly what I want to do. And, so, but it's not like, so what I hear you saying is, I just develop some language, write down, try them. Try them out on your patients. Just test some new, write them down and take them to work and put it on a sticky note, and do whatever you need to do. Write it on your hand, write it on the glove, but just try them. And try to find the words that feel comfortable for you. Don't try and be me. Don't try and be somebody else. Try and be you. And, for me, it's kind of like, so it sounds to me like what you really want to do or what you want me to do for you. And, that's how I approach the patient. And then at the end of every appointment, and these are 2 customer service questions that we should always ask every patient on every visit. And I learned this from John DeJulius, What's the Secret to World-Class Customer Service. That is a great book. We had him at the Oregon Dental Conference years ago. I would highly recommend you and your team read that as well. But I always ask my patients, I always end with, I thank them for coming in, and it's like, have I answered all of your questions today? I want to make sure that if you have any questions, I want to answer. Have I answered all your questions? And then number 2, is there anything else I can do for you today? And typically they say, yes, you've answered all my questions, and no, thank you so much. But if there is something else that they have on their mind, I get to find out what that is as well. So, these are open-ended questions. I want you to write some of these down. I want you to just take them to your practice and try them. Try them with the patients instead of thinking about how this patient has this organized treatment plan of how you want to do it. Think about open your mind to the possibility that maybe it doesn't matter if you do. There are some things that have to be done sequentially, but beyond that, does it really matter if you do the crown on 19 before you do the crown on number 5? Does it really matter if you do this before that? And if it doesn't, let the patient have control, because the more you put the patient in control, the less resistance or rejection you have to your treatment plans. So my conclusion tonight, once patients have confidence in their health, that they know what's causing their health issues and they feel like they're in control of that, they choose better care. In fact, they choose complete restorative care. You want to do more restorative dentistry, help your patients get rid of, help figure out what's causing their disease. I would tell you that diet and home care are potentially modifiable. We're human beings we're talking about here. Not everybody is going to be successful, but they're potentially modifiable through a coaching process by asking open-ended questions. And then just understand behavioral change takes time. It's not 21 days. It's years, and it's not linear. The patient that I shared with you tonight, she got better, and the next appointment she'd slip a little bit, and then I'd coach some more, and then she'd go out, and 3 months later she'd be better, and it was kind of this 2 steps forward, 1 step back, and it went that way for 4 years. But she's made slow, continual, steady progress. And at the point where I thought that she was under control, then we went ahead and did some of the definitive restorations for her. So, so that's kind of my approach to coaching. I hope that you found that this presentation helpful tonight. It's a lot of information, and it's a lot of I hope there were some new questions that you could take away from here tonight that you can start using with your patients. But I hope that I helped you understand, sometimes what's going on inside of your patient's head, and maybe asking the question on how to find out what that happens to be. So Cody, that's my presentation for tonight on coaching. I know that we've got some questions. We always do, and we have time tonight for a few questions. So I know. Fire away.
All right. So we've had quite a few come in, and I don't think we'll be able to get to all of them, but we'll definitely have some time for a few. And then, like I said earlier, we'll get back to the other ones later this week. But the first one is, what is the best way to identify that a patient has a bacterial issue specifically?
That's a good question, Cody. And so there's two ways that I look at that. Number one, if we're talking about overall bacterial load, like if the person has a plaque issue, like my patient tonight, I mean, you see the plaque accumulating on their teeth. You see active white spot lesions. Now, it could be that the patient comes in and they're pretty clean, like their gums are pretty red, like they really scrubbed their teeth right before they came to see you on their checkup. But if they've got those telltale white spot lesions, particularly on the class 5 area around the gingival margin, and an active white spot lesion is dull. When you blow air on it, it's dull. A shiny one is arrested. So that's the way that you can tell the difference between those two. So if you see that they have active white spot lesions, or you see plaque built up on their teeth, that you know you've got an issue there. Now, I also use ATP, and ATP unquestionably measures bacterial load. We're actually expanding that to maybe even some other general health considerations that I'll be talking about later on this year. But certainly we know that unquestionably it measures overall bacterial load, and we also know that there have been a number of scientific studies where it correlated to high levels of mutans streptococci, and hence, I mean, we would extrapolate that to say acid uric bacteria, because we know that the acid uric bacteria, that's one of their adaptive mechanisms to survive. So high levels of ATP or visual signs in the mouth. So those are the two things that I would kind of base my my judgment on that on. That's a great question, Cody.
Perfect. Well, the second one kind of maybe goes into a little bit of that too, and it's how long is the typical treatment time? And then just sitting here thinking, maybe if you could expand a little bit on how you relay what the expectation for patients would be.
Yeah. You know, when I started doing this 15 years ago, I thought this was going to be like I thought it was going to be a 21-day deal, right? Because we all believe that. And I was sadly disappointed to find out it wasn't a 21-day deal. And then I thought it was probably a 3-month situation. Like, I was pretty sure I could correct the bacteria in anybody's mouth in like 3 months. And actually, in fairness, that works for some patients. And then there are some patients that 2 years later, or this patient tonight, I mean, that's you're looking at a 4-year end result there. So it is still going on. So it's maybe a years-long process. So I don't set the patient up with this expectation of, here's this magic rinse. There are no silver bullets for dental caries. There are none. You know, here's the best thing that I can put in your hands for the issues that you have. You're going to need to use this once a day. You're going to need to, we're going to talk about how you're going to accomplish that as a new habit. But I'm going to put that in their hands with the expectation of this could take months. It could take years. And so I don't want to set them up for failure by expecting that this is going to 30 days later you're going to, all your bacterial issues are going to be solved. So, because I don't want you to be disappointed when they're not, because this is a behavioral issue and it does take time. I mean, we learned from the scientific evidence tonight, 66 to 254 days. I mean, that's basically, almost a year, and that's consistent with other studies as well. So I would say it's longer than shorter. It's more like months to years rather than days to weeks. So that's kind of, but then it varies by the patient and how motivated they are and how successful they are at making that change. So it varies by individual, and it varies, the length of time varies from patient to patient. So I think that's probably the best way I can answer that, Cody. Just don't prejudice the patient's expectation to think that this is going to be a 30-day or a 90-day silver bullet, because it doesn't work that way.
Right. And maybe the last one we have time for here. If my patient has more than one of the usual suspects that you obviously talked about earlier, right, how do I decide which treatment plan is best for them, or treatment option?
Okay, so if I get the question correct, and that really relates back to our patient tonight, and whether it was diet or xerostomia or from medication, I can't take them off their medications, but again, if they have multiple risk factors that they need to make multiple behavioral changes around, I would go back to, in the early days, I threw the book at them. It's like, you got to do this, 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 and this, and now it's like, okay, so here are the issues. These are the things, if you want to get healthy, that you're going to need to make changes about, and which one, and I'm going to help you we're only going to tackle one at a time. I want you to just, you pick. And I used to pick. I mean, when I first started, I go, okay, you need to do this first. And I thought, well, that's stupid. You know, what if the patient's really more motivated to give up Mountain Dew than to start brushing? And if I try and force them to start brushing and they don't really succeed at that and they're still drinking the Mountain Dew, I haven't gained anything at all. In fact, they weren't successful at brushing, so they're not even going to, so that failed, so then I'm probably not even going to try giving up the Mountain Dew. So I really like to go to the patient and put them in control, put them in charge, put the work on them. Which one do you want to do? Where do you want to start? And then tell me, what's your plan? How are you going to do that? Explain to me how you're going to remember. You know, what are you going to target? How would you like me to remind you or bring this up again at our next appointment? How would you like me to coach you through this? You know, is it okay if I say, gee, I noticed that you've got a lot of plaque on your teeth. Looks like you still have more work to do on the toothbrushing. How's it going? Is there something more I can help you with in terms of, you know, establishing that new habit? So I always like to put it back on the patient. Let them pick. You know, if at all possible, let them pick, because they're going to pick the one that they're most interested in and most likely they'll be most successful at out of the gate. And then you've got one in the win column, and then you know, they have more confidence to try and put a second thing in the win column. So that's been my experience with coaching. That's it. Those are great questions tonight, Cody. I hope everybody enjoyed this webinar as much as I did. I love coaching. I love this aspect of what I do in terms of helping people, because it makes such a huge impact in their life when you can make that kind of change. So it's really just emotionally probably the most rewarding thing I do in my dental practice. So as you can tell, I'm passionate about it. I'm excited and I have fun. So I appreciate all of you for spending your time with me again. What's that, Cody?
I said we definitely can.
So I appreciate, once again, it's 2016. We're on a new year. This is one of my favorite topics. We started the webinar series off this year with this topic, and we've got some more exciting things coming. I know we've got another webinar next week, but there'll be some more interesting things developed that I'm excited to share with you as the year goes on. So I look forward to having another great year with all of you out there in our chosen profession. So thank you so very much for spending your time with me.
Perfect. I think that'll wrap it up. Thank you, Dr. Cooch. Thank you to everyone for joining us tonight. Again, if we didn't get to your question, make sure to check your email and we'll get back to those later on this week. If you want to hear anything or any of this again, we are going to send out a recording, so look for that. And please give us a call if you're interested in learning about implementing more or implementing Carifree in your practice. We can certainly set up a webinar one-on-one with the team and kind of answer questions and go over that. So thanks, everybody. Have a great night.
Yep. Good night, everybody.